Okay, we're gonna go ahead and get started. Sorry about the delays, guys. I'm clearly technically challenged today. All right, so we're gonna start the PICU intern lecture series with talk about vasoactive substances, so pharmacologic support of the circulation. Hopefully, this is not how you guys feel as you enter the PICU, but hopefully these talks that we do over the next few weeks are going to help you feel a little bit more ready as we move forward. So today we're going to talk about the different adrenergic receptors that are going to be really important in how all our vasoactive substances work. Then we're going to talk about all those sort of classic inotropes and how we use them in different circumstances in circulatory failure. We'll talk about some of the newer inotropes and how we use them in circulatory failure. And then we'll end with some case scenarios and inotropic choices, kind of how we would work with them in more real life situations. So when we think about circulatory failure and shock, what we really have is a failure of the body to deliver oxygen and substrates that meet the metabolic demands of the tissue beds. So it's really all about supply and demand. And what also happens as you're not delivering substrate, as you're not delivering oxygen, as you're not perfusing those tissue beds, you're also not removing metabolic end products, which start to build up. So things like lactate, things like CO2, etc. This is, in general, a result of inadequate blood flow or adequate blood flow without adequate oxygenation. And what happens as this progresses is we get a transition to a much more anaerobic metabolism and the development of metabolic and lactic acidosis. All the cellular energy-dependent processes start to slow down and or cease, resulting in cell edema, cellular disruption, and cell death, and ultimately then organ failure. When we talk about inotropes, really these have been the therapeutic cornerstone of managing shock, managing acute circulatory failure, regardless of what the cause of that is. So if you have insufficient cardiac output for the demands of the body, or you simply have low perfusion pressure despite an adequate cardiac output, you're going to use your inotropes to help manipulate those hemodynamics. It's going to be really important to remember that no inotrope works by altering contractility alone. Now, this can be a really good thing, or it can make things a lot more challenging, right? Because all those other effects and or side effects of our inotropes, things like elevated heart rate or increased myocardial oxygen consumption, can either work for you or work against you as you're manipulating the circulation. So when we think about then the circulation in a small child and what helps generate blood pressure, you have to think about the different components of that. So blood pressure is a combination of your cardiac output times your systemic vascular resistance. We should all know that cardiac output is determined by heart rate times your stroke volume. And I'll remind you that small children, infants in particular, are not able to manipulate their stroke volume. They cannot change that in the setting of stress or shock. So they're really very, very heart rate dependent. Right? So that's all, they're all chronotropy dependent. When we think about what alters stroke volume, it really is your end diastolic volume. So what's your preload? What's your circulating volume status? As well as lusitropy, right? So is the myocardium able to relax adequately during diastole to allow for ventricular filling? Minus the end systolic volume, which is impacted by inotropy. How much can the heart squeeze? How forcefully does the heart squeeze to eject blood from that left ventricle? And what's the afterload? What is the heart working against with each contraction? So your cardiac output obviously is dependent on many, many, many factors that inotropes and pressors are going to help you manipulate. A shock comes in a variety of flavors. You can have shock in the setting of elevated systemic vascular resistance, and that you're going to see that in cardiogenic shock. You will see that in pure hypovolemic shock. You'll see that in obstructive shock, and you may see it in cold septic shock, right? This is where you've got the peripheral vascular bed clamping down, raising systemic vascular pressure and resistance in order to shift blood flow to the more crucial vascular beds. Versus low systemic vascular resistance states like warm or vasodilatory septic shock, profound metabolic dysfunction, multiple toxidromes, neurogenic shock, and variety of endocrine dysfunction. So when we think about our catechol or our sympathomimetics, they're going to mediate their effects via 4 different types of receptors: the alpha-1, beta-1, beta-2, and dopaminergic receptors. The density and the proportion of all of these receptors are going to modulate the physiologic response, right? With your alpha receptors primarily impacting smooth muscle contraction and other transmitter releases, whereas your beta receptors are going to impact heart muscle contraction, smooth muscle relaxation, and a variety of other metabolic and endocrine activity. So we think about our receptors in a little bit closer detail. Our alpha receptors are our prominent receptors in our vascular bed, although they are present in the neonatal myocardium. And so NICU babies, brand new newborns, their receptor densities and locations are a little bit different, and so we will often manipulate our pressors slightly different in that demographic. Alpha receptor activation will lead to contraction of the vascular smooth muscle, which is going to increase your systemic vascular tone. This happens through an increase, ultimately, in cytosolic calcium. So when we look through this, we see a change in phosphatidylinositol type 2, leading to an increase in cytosolic calcium and vasoconstriction. Our beta receptors work a little bit differently. Beta 1, we're going to see enhanced myocardial contractility. This is going to be, again, calcium-mediated facilitation of your actin and myosin complex binding to troponin C. This calcium channel continues, even in this setting, to be the final pathway of most of our pressors, which is why calcium becomes so important with the receptor activation. What we'll also see is enhanced chronotropy, or an increased heart rate with beta receptors, also triggered through calcium channel activity. But you have to be careful with this because it may cause some dysrhythmias. You may also, as a result of your beta activity, beta-1 activity, see some increase in renin due to its impact on your renal juxtaglomerular cells. Beta-2 receptors work a little bit differently. You're going to have an increased intracellular calcium uptake by the sarcoplasmic reticulum. So we're going to actually pull calcium out of the cytosol back into the SR, kind of reversing a lot of the processes we've talked about, leading to vasodilation of that vascular smooth muscle. So for those of you who think a little bit more in picture or flowchart form, on the left-hand side, you have your beta-1 receptors that through activation of your calcium channels and an increase in cytosolic calcium, you have both an increase in inotropy and chronotropy. Whereas your beta-2 receptor side, you have more calcium taken out of the sarcoplasmic reticulum, out of the cytosol into the sarcoplasmic reticulum, resulting in vasodilation. Okay, so I'm going to remind you guys here, and calcium should be sort of a theme that you guys are picking up on now with all of this. Your beta-1 and beta-2 receptors can develop tolerance. They can become desensitized to your catechols and your sympathomimetics, so that over time, the treatments that you're giving may seemingly become less effective. So we always have to be on the lookout for that. We also have to take into account dopaminergic receptors, which are found primarily on your renal and your splanchnic vascular beds. But by activating those, you may see further modulation in reflex autonomic changes, especially if you've had a big change in your blood pressure. Lots of second messenger systems are involved in activation of the dopaminergic receptors. So if we think about that in the background, think about how those receptors act and what their function is, like what their net effect is when they're activated, it should start to make more sense when we start talking about the different vasoactive substances, how we use them, and why we use them under specific circumstances. So endogenous catechol synthesis starts with phenylalanine and works its way to dopamine. Dopamine then being the precursor for both norepinephrine and epinephrine. So even if we're choosing as our pressor to start with dopamine or norepi, we may actually be in effect increasing epinephrine levels as well. Starting with dopamine, as I said, this is an endogenous catechol, but it's also an endogenous central nervous system neurotransmitter, which acts on both the dopaminergic and adrenergic receptors. And dopamine has very specific dose related effects, okay? So again, it's that immediate precursor to norepinephrine. So when you're using dopamine, roughly half of dopamine's effect may actually be the result of an increase in your norepinephrine levels. At very low levels of dopamine infusion, what we start to see is your dopaminergic 1 postsynaptic receptors on renal, coronary, mesenteric, and cerebral vasculature. Historically, like back in the day when I was sitting in your seats and dinosaurs roamed the earth, we used to talk about renal dose dopamine, this very, very low 1 to 3 mics. Oh, it's going to cause renal vascular vasodilation and protect against renal failure when people are really sick in the ICU. Well, that's completely fallen by the wayside. So don't ever say that, because then you'll sound stupid, and we don't ever want you to sound stupid. So we really tend not to use this 1 to 3 mics per K per minute of dopamine at all. And we'll really usually start more in the 4 to 5 as our starting dose. At that 4 to 8 mic per K per minute dosage, what we're going to see is dopamine really acting mostly on your beta 1 receptors, kind of weakly, but leading to norepinephrine release and inhibiting reuptake of norepinephrine. So what we see at 4 to 8 mics, 4 to 10 mics roughly, is an increase in contractility, an increase in heart rate, and a mild increase in systemic vascular pressures. As we get to higher and higher doses of dopamine, so really greater than 10 mics per K per minute, we see a lot more alpha-mediated effect and a lot more peripheral vasoconstriction. In our older children in the PICU setting, we're generally not going to go above 15 or so of dopamine before it maxes out. But you'll see higher doses up to 20, maybe even 25 mics per K per minute in the NICU. Again, and that goes back to the sort of receptor densities, and where they live is a little bit different in the neonatal myocardium and the neonatal vascular bed. So for those of you who think more in chart form, I've got a chart for each of these pressors looking at what their receptor effect is. All right, when we look at dobutamine, dobutamine is a little bit different. And you'll notice I didn't mention it in that early slide that showed the synthetic pathway. And that's because dobutamine is a synthetic catechol that works primarily on beta 1 and beta 2. Okay, so this isn't one that our bodies make on our own. This is one that some super smart chemistry guy came up with in a lab. But its result effect when we give it to a child is very potent inotropy, but with a lot less impact on heart rate. So what we get is vascular smooth binding, muscle binding. We have a little bit of alpha-1 agonism and antagonism plus the beta stim. So what we see with dobutamine's net effect is a lot of inotropy and actually a little bit of peripheral vasodilation. So you're lowering your peripheral vascular tone and increasing the force of your myocardial contraction. So your net effect can be a little bit unpredictable. Sometimes we'll actually see a lowering in blood pressure. More often than not, however, we will see the blood pressure go up. I said that it works on beta 1 and beta 2. So its sort of ratio to effect is beta 1 is about a 3-to-1 to beta 2. So you have much more beta 1 than you have beta 2 affinity and impact. Again, with dobutamine, we're going to see a dose-dependent increase in your cardiac output. The more you go up on the dobutamine, the more your cardiac output is going to go up. And you'll have improved left ventricular filling pressures, which is great, right? Because as your left ventricle fills better, you're going to have better coronary perfusion, which becomes important because dobutamine really does, because of that impact on its inotropy, those stronger, more forceful contractions chew through oxygen, right? So you have a big increase in your myocardial oxygen demand in the setting of dobutamine. So the fact that it allows for better ventricular filling can help offset that a little bit, right? But you do have to worry about coronary ischemia, and you do have to worry about sort of malignant dysrhythmias in the setting of dobutamine. So dobutamine we're going to use in low cardiac output states like decompensated heart failure or cardiogenic shock, or in the setting of septic shock with decreased cardiac function. And again, as you see, what you'll see is as you go higher and higher on your doses, you start to see a little more alpha, but your primary effect of dobutamine is beta 1. That's your biggest bang for your buck there. So chronotropy and inotropy with dobutamine. Norepinephrine, moving back to our endogenous catechol. So again, another endogenous neurotransmitter comes from our postganglionic adrenergic nerve terminals. And this is a powerful, powerful vasoconstrictant. So very, very potent alpha effects with minimal beta 1 agonist activity. So we don't get nearly as much squeeze and we don't get nearly as much heart rate elevation. This works a lot more in the periphery, right? This is going to be our peripheral vasoconstrictor of choice. So what you end up having when you start your norepinephrine drip is an increase in your systolic blood pressures, an increase in diastolic blood pressure, so your perfusion pressure gets better, and you have very little change overall in your cardiac output. That again, going back to the diastolic blood pressure, improving diastolic blood pressure improves coronary blood flow. So that's a win, that's a good side effect in most shock states. So again, norepinephrine is our go-to drug in vasodilatory shock or in some circumstances of cardiogenic shock, with alpha 1 as our sort of predominant player here. And then epi, my favorite drug. Epi in the ICU is like your very bestest friend. It's hard to go wrong with epinephrine. And I would say if you don't know what to start, ask for epi. It's pretty good multi-purpose for almost everything. It's our major endogenous catechol, and it's our end catechol when we look at that synthetic pathway. It's going to work on alpha 1, beta 1, and beta 2 receptors in both the heart and the vascular smooth muscle. And again, you're going to see changes in which receptor is the major player depending on the dose. So again, dose-determined effects. You see increases in coronary blood flow due to local vasodilatory effects that on the coronaries that epinephrine will have. And although the heart rate goes up in the setting of epinephrine infusion, what we also see is a longer time in diastole, a longer portion of the cardiac cycle in diastole, which will increase coronary blood flow and will help that struggling myocardium. We'll also see an increase in pulmonary blood flow due to improvement in both pulmonary venous pressures as well as pulmonary arterial pressures. For reasons that aren't 100% clear to me, the right side of the heart, when it's failing or is struggling, really likes epinephrine. So in the setting of right-sided heart failure, epi is very helpful. We're going to use epi for all flavors of shock. You're going to use it obviously in the setting of cardiac arrest, anaphylaxis, and severe bronchospasm. And as I mentioned before, again, you've got dose-dependent effects. So at lower doses, you definitely still have alpha. You still have some peripheral vasoconstriction, but you get a medium amount of chronotropy and inotropy. And at very low doses, you may actually see a little bit of peripheral vasodilation, which I think seems very counterintuitive. I think we always think of epi as the thing that ramps everything up. Heart rate, blood pressure, squeeze, the whole bit. But at very low doses, your net effect may actually be a little bit of peripheral vasodilation plus a boost in chronotropy and inotropy. As we get to our more normal dosing of epinephrine, then we start to see really alpha-1 and beta-1 taking over, and we lose that peripheral vasodilatory effect. Isopril or isoproterenol is one that we're probably not nearly as familiar with in pediatrics. We don't use it a whole heck of a lot, but this is our pure, again, synthetic, pure, non-selective beta agonist. So it essentially has no affinity for alpha at all. So if you think about what our beta-1 and beta-2 receptors do, you're going to get your very powerful chronotropy, very powerful inotropy, but you're going to get systemic and pulmonary vasodilation. Very commonly see arrhythmias with this, but what we're going to use this for is when we have horrible bradyarrhythmias that are associated with heart block. You're going to give a boost of isopril and you get the patient's heart rate back, but you may actually need to add a little something else to go along with it because of the potent effects on the peripheral vasculature. So again, no alpha, lots of beta-1, lots of beta-2, giving you heart rate, cardiac output, and peripheral vasodilation. Phenylephrine, we do use a little bit more in peds, and anesthesia loves phenylephrine. This is their little keep it in your pocket, give a little squirt when you need it kind of drug. And that's because it's pure alpha, no beta at all. So this is your pure peripheral vasoconstrictor, right? So if you've got things like basally mediated hypotension, neurogenic shock, spinal shock, or a little bit too much anesthetic, or some hypotension from vasodilation related to an anesthetic, that's why anesthesiologists love this so much, you can give a little squirt of phenylephrine. What you'll see here though, is you can get huge boosts in your systolic blood pressures, which result then in a reflex bradycardia. So the heart rate often drops when you use phenylephrine. Okay. Shifting gears from sort of our classic vasoactive substances that work on our alpha and beta receptors, we're going to switch gears a little bit now and talk about milrinone. So milrinone works completely differently. Milrinone's our phosphodiesterase inhibitor, and what it is going to do is it's going to use those effects to increase cyclic AMP by inhibiting its breakdown within the cell, thereby increasing myocardial contractility. So for those of you who think in pictures, your phosphodiesterase inhibitor comes in and blocks the effect of phosphodiesterase 3, so cyclic AMP does not get broken down as much. Okay. So what you see then is going to be an increase in intracellular calcium. Again, working to help improve cardiac output. So what you get with milrinone, we think of this as our inodilator. You get potent inotropy, but lots of vasodilation in the periphery. Okay? What you're going to see is an increase in general in your cardiac output, but without significant increase in your myocardial oxygen demand, which is a bonus if the heart's struggling or the perfusion to the heart is a challenge. It will also help improve coronary blood flow while increasing your systemic vascular resistance and your pulmonary vascular resistance. I'm sorry, decreasing systemic and pulmonary vascular resistance. Now, your inotropy to vasodilator effects, the ratio there is about 1 to 20. So in general, it's a much more potent vasodilator than it is inotrope. And so milrinone is often used as like a bonus drug. It'll be used in conjunction with epi or with norepi, depending on the type of shock. The other bonus that milrinone has, and this is huge, is its effect on lusitropy. So again, we talked about this a little earlier. Lusitropy being the ability of the myocardium to relax. And if the myocardium can relax more effectively, you will have better ventricular filling, better ventricular preload, and so an increase in stroke volume, right? And if you think about cardiac output being stroke volume times heart rate, milrinone can be very, very helpful in that setting. So we're going to use milrinone primarily in the settings of low cardiac output to improve contractility, coronary blood flow, to decrease systemic vascular and pulmonary vascular resistance, to improve lusitropy and ventricular filling. Now, you can get a lot of hypotension with this, so you want to be careful. And this has a longer half-life. Milrinone has a much, much longer half-life, and it is renally excreted. So we're going to have to use this with a lot of caution when you've got kids who have marginal blood pressure to begin with, or who have markedly impaired renal function, because it'll stick around for a really long time, and that can be a harder hole to dig out of. Lastly, we have vasopressin. This is probably a little bit newer on the scene as far as using it in this as a vasoactive substance than some of the other drugs. So vasopressin is a nonapeptide. It's stored in your granules in the posterior pituitary gland, and it's released in response to many, many, many physiologic stressors. So basically any stressor that you can think of, vasopressin is going to be released. So obviously shock, dehydration, alterations in serum sodium and serum osmolality, pain, anxiety, nausea, respiratory compromise of any sort. The list really goes on and on and on. So our bodies use vasopressin in basically any sort of stressful situation. It works on multiple receptors, the V1A receptor being the one that we're really going to think about in the setting of shock. That's the one that lives on our vascular smooth muscle, the V1A receptor, and it leads to very, very potent vasoconstriction. Vasopressin, when it acts on that V1A receptor, is a more potent vasoconstrictor than angiotensin II or norepinephrine. It's our big, big gun. It works on V1B in the pituitary, and then when we have things like salt and water imbalance as a result of diabetes insipidus, it acts on the V2 receptor in the kidneys and the collecting ducts to hang on to free water when the kidneys are just dumping water out. But again, this is going to be our big gun when it comes to vasoconstriction. The other bonus that vasopressin has that I think is not to be minimized is that it really sensitizes the patient to the effects of all of our other vasoactive substances. So I told you that vasopressin is released endogenously in the setting of stress for any number of reasons. When kids get really, really, really sick and they are in shock, they're often vasopressin deficient, and so they can't mount that appropriate response. And so giving them back a little tiny bit, all of a sudden everything gets better. And all those vasoactive substances, the norepi and the epi and everything else you've been dumping in at very high doses, all of a sudden, in the presence of having a little bit of vasopressin given back, they all just start to work that much better, and you can often dial your other pressor support way back. So I said it works via osmotic receptors that we will pick up an increase in osmotic pressure and then lead to vasoconstriction of the blood vessels, leading to an increase in blood pressure. You'll have an increase in free water reabsorption from the kidney. So that's going to increase your preload, increase your intravascular volume, also helping to increase blood pressures. Historically, this had been used in cardiac arrest and PEA. Newer literature has found that ROSC is not any more effective, more effectively achieved with giving vasopressin in PALS and ACLS, so that has been removed from the ACLS algorithm. So when we talk about vasoconstriction, again, just a reminder, vasopressin is going to block your potassium-mediated ATP channel. It's going to decrease nitric oxide levels, so then nitric oxide doesn't impact myosin and myosin phosphorylation, so the myosin stays phosphorylated, and you have constriction of the vascular smooth muscle. And calcium is allowed into the cell, into the cytosol from the extracellular space, increasing cytosolic calcium and also contributing to smooth muscle constriction. All right, too many X's. I don't know where my vasodilator slide went. So again, vasopressin in the set of vasodilatory shock. I set this slide up a little bit differently. So we use vasopressin in milliunits per kilo per hour. So very, very, very low dose if we want to impact that V2 receptor and impact free water reabsorption in the kidney. So basically that's for DI. We use units per kilo per minute, so our high dose vasopressin drip, which will impact your V1 receptors and actually treat shock. When you guys order this, they use tall man letters. There's 2 different orders, and one will actually say for shock and one will actually say for DI when you type in vasopressin into the box. So we tried to do everything we could not to screw it up, but just so that you're aware, you're going to be ordering it per hour for DI and per minute for shock. I talked a lot about calcium and its impact as we moved through all of the different vasopressors. I don't want you to forget, calcium really is essentially an inotrope in and of itself. It is necessary for basically all of those inotropes that we talked about to work. If you do not have adequate calcium stores to move back and forth into the cytosol and into the sarcoplasmic reticulum, you are not going to be able to achieve chronotropy, inotropy, or vascular smooth muscle constriction. Infants and small humans are particularly sensitive to this. And so very small babies will often actually put on a calcium infusion to maintain their calcium levels and use that actually as a vasopressor. Older kids, teens, we don't see quite as potent an effect, but you'll definitely see that if your ionized calcium level in those kids is low, like 1.0, 1.05, your pressors just don't seem to work nearly as well. And so I put this on here for you to remember. We're going to keep a close eye on our ionized calcium in any of these kids who are in shock, who are needing vasoactive substances, because you're really going to want to keep it in a normal range. But this isn't a situation where if a little bit is good, more is better. Not the case, right? Calcium, intracytocellular calcium, also plays a big role in cellular apoptosis and cell death. And so we don't want to overshoot the mark to raise that intracellular calcium level so high that we're killing off myocytes, right? If the heart's already struggling, we don't want to kill any more myocytes. We don't want to rob Peter to pay Paul. So we really want to maintain normal ionized calcium levels. They don't necessarily need to be supraphysiologic. Levosimendan is being used a little bit more in Europe and on the adult side as a calcium sensitizer. So increasing calcium surrounding your contractile protein. So basically attacking the problem from a slightly different angle, opening up those potassium-mediated ATP channels and allowing for better binding to troponin C. So you get more contractility without necessarily increasing the intracellular calcium or affecting relaxation. So it's basically just making the cells more sensitive to the calcium that's already there to help improve cardiac function and cardiac output. Vasodilation, as we talked about, is going to be primarily as calcium leaves the cell, mediated by nitric oxide, and as potassium leaves the cell as well. Myosin, in the presence of nitric oxide, will get dephosphorylated, and so the vascular smooth muscle will relax. Okay, before we move on to patient scenarios, I think somehow in all the kerfluffle getting this organized, a couple of I loaded an older version of this lecture. I want to talk a little bit about vascular access and what you need in order to deliver these drugs. Okay, so starting with worst case scenario, kid is in extremis, kid is in shock, you don't have access, you want to put in an IO. Every single vasoactive substance that we have talked about can go through an IO. It is your ultimate central line. If you're going to do that, you need to be very, very careful to keep a close eye on the soft tissues surrounding that for infiltration. Because if you infiltrate your epi drip into that kid's calf, they're going to lose the leg. And I've seen kids lose limbs from this. So if you're going to use your IO, which is your best rescue maneuver in this setting, just keep a very close eye that you're not infiltrating, that calf muscle behind the posterior tibial plateau is not getting firm, is not filling up, and that line is functioning adequately. Other central lines, so either your percutaneous line that we're going to put in right at the bedside, or your umbi lines in the NICU, or your Port or Hickman or Broviac, your tunneled surgical lines that the hem-onc kids might have. Again, any of our vasoactive substances can go through those lines. And those you don't have to worry about nearly as much about infiltration. So IO or central access that's already there, you're good to go. Putting in a central line, an IJ or a femoral line, or a subclavian line in a shocky, critically ill, not all the way volume resuscitated child can be a very challenging and very time-consuming process, and we don't want to ever delay getting those vasoactive substances started just because we're trying to put in that central access. So go with the IO, or some of our vasoactive substances can be run through a peripheral IV. Okay, so things that can go through peripherals will be dopamine, up to 10 mics, epinephrine up to 0.3 mics, milrinone at any dose, dobutamine at any dose. So if you think about that, those are really your lower potency vasoconstrictors or the drugs that will cause vasodilation. Those are going to be safe to go through a peripheral. Things that you will never, ever, 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 under pain of death, put through a peripheral will be norepinephrine and vasopressin, right? And that should make sense, right? You're not going to put your most potent vasoconstrictors through a peripheral line that could infiltrate, because you will kill the tissue. So anything that causes vasodilation can go through a peripheral, or your weaker vasoconstrictors, right? But if you're doing that, you're going to be simultaneously working on getting central access so that you have something stable and safer to put the line in. That is sort of rescue therapy, right? Is to run those through a peripheral. Okay, I've thrown a ton of information at you. I don't know if I have a way of figuring out how to go to the chat. I'm trying to figure this out. Or see if you guys have questions for now.
You guys have any questions, you can type down in the chat. I can keep an eye on the chat for you, Dr.
Okay.
Fitz, while you're talking.
Or we can move on to just some scenarios and talk through some scenarios.
Yeah. Yeah, no questions yet, so maybe with the scenarios.
Let's go through some scenarios then. Okay, so patient number 1 is a 12-year-old admitted to the PICU, intubated from the operating room. The patient presented to the emergency room with fever, abdominal pain with rebound and guarding, and a KUB revealed free peritoneal air. Child was taken emergently to the operating room where they found a ruptured appendix with severe peritonitis. On arrival to the PICU, the child is 38.8, heart rate is 165, rests are 20 on the ventilator, blood pressure 70 on 45, but satting 98%. Child is flushed with warm extremities and bounding pulses. What's our diagnosis? I don't know if you guys want to go off.
Yeah, so Lena said septic shock.
Okay, let's add a couple other adjectives to septic shock. I agree with that. But when we're talking about our pressors, we need to know we have to have some qualifiers on that.
Warm shock from Allison and Jenna and Diana.
Okay, yeah, so warm or vasodilatory septic shock. So in that setting, what pressors are your best choices? What are you going to start?
Give it your best guess, guys. What would you use for vasodilatory shock? So Mark said epi.
Okay. Okay. So what would the so epi is great in a pinch. I'll give you that. What's the ideal pressor combo for warm shock? What would the sepsis guidelines tell us? Do we know?
Norepi. Good job.
Norepi. Yeah. Okay, so if you think about this, what's happened? The heart's probably working okay. You've got enough chronotropy, but the bucket, the vascular bucket, became infinitely large, right? Because you're so vasodilated. So what this baby needs back, what this child needs back, is peripheral vascular tone. So norepi is going to be your go-to drug in the setting of warm septic shock. Okay. But that's got to come from the pharmacy, and they've got to mix that. And are you going to sit and like just watch this happen for the next 45 minutes while they're like having coffee and mixing up the bag of norepinephrine? What can we use in a pinch that we have right there at our disposal?
So along that same line, Ryan did have that question. If a kid is going into shock and you don't have central access, what do you usually start with? Diana said dopamine.
Okay. And that's the answer to actually my question and to Ryan's question. Right? Dopamine, I think of as the Band-Aid pressor. It's ready mixed. It's there in the AccuDose or the Pyxis or whatever the hell we call that machine in the back. You can grab it and you can hang it, and it can go peripherally up to 10 mics, and it's right there ready to go. So if you need a quick Band-Aid and you're trying to capture the physiology, go with dopamine while everything else is being ordered stat. Okay. Epi, Mark, you're not necessarily wrong, because that could go through the peripheral and it can buy you a little bit of time while you're waiting for your ideal pressor, which in this setting would be norepi. Does that make sense to everybody? I'm going to assume silence is yes.
I said it's good.
Okay. Okay, so now we've continued with our aggressive volume resuscitation in the PICU for his warm vasodilatory septic shock. Started his norepinephrine and added a little dobutamine as well, but the patient is still hypotensive. So still in shock despite sort of maximizing our first line therapies. What do we want to do next? What would you add next? If I tell you this patient is still warm, is still having bounding pulses, and is still 65 on 40.
Lena suggested phenylephrine.
Okay.
Vasopressin from Ryan.
Okay. Phenylephrine, I would use sort of as your Band-Aid in this setting. Right.
Did you hear vasopressin?
Yeah, so vaso is usually our next step in the set once we've sort of are using escalating doses of our standard, especially in sepsis, of our standard pressor support. Remember, we talked about patients who are critically ill like this being vasopressin deficient, and that vasopressin, adding that in, will sensitize the patient to our other standard inotropes as well. So usually we'll add vasopressin sort of as our next step here. Okay, now I will warn you, all of the PICU attendings have a slightly different threshold for when they will start vaso. I love vasopressin. I'm an early vasopressor sort of gal, okay? So I will often order it sort of in anticipation of needing it. Some of my colleagues will wait a little bit longer, but I want you to understand when to use that sort of in your armamentarium and when to start asking about it when you're on call. Okay. You guys good on that case? Questions or other concerns? Okay.
I think they're good.
Okay, so now we have a 6-month-old, previously healthy baby with a day of fever, respiratory distress, and poor PO intake. On arrival, the infant is clearly in extremis. Temperature is 34.1. Heart rate is 85. Rests are 70. And since you're out at St. Swithern of the Swamp, they tell you that they're unable to get a blood pressure. The SATs are 82. The child is cold with mottled extremities, and they're telling you that the cap refill is 5 seconds. What does this baby have? What are we worried about for this child?
Lena said cold shock.
Okay. Okay. So cold shock, what else could this be? What other flavor of shock could this be?
Cardiogenic, someone said.
Yes. Yeah. So right when they roll in, you may not be able to tell, is this cold septic shock? Is this profound hypovolemic shock? Or is this cardiogenic shock? Because they all may look very similar at first glance, that high SVR shock state. Okay. So, and this is complicated also by respiratory failure. right? So we've got a couple different things that you're going to have to juggle with this child, not just their hemodynamics, okay? So what are we going to do for this baby? You guys haven't worked with me so much, but your go-to answer whenever I say, what do you want to do? If you say ABCs, I'm going to smile. Right?
Dopamine.
Okay. Okay. So dopamine while we're in crisis mode. All right. All right. So let's start with A. Does this baby need an airway?
Yep. Someone said oxygen.
Yes.
Some type of.
Oxygen is at a minimum, but this kid's really, really sick. So we're probably going to just intubate right away. All right. What are you going to do vascular access wise? You think this is going to be an easy peripheral IV? Do we have time to monkey around?
Yeah, Selena said IO if very emergent, which this kid sounds emergent.
Right. Exactly. You're going to pop in that IO while you're having them get ready for your intubation stuff. And as soon as that IO is in, what comes next? How about some IV fluids? Right? So you're going to give volume while they're getting your pressor ready. And you guys said, start with DOPA. Okay, that's going to be your Band-Aid. What's
Epi.
our pressor for cold shock?
Selena said epi.
Epi, right. So you can use your DOPA as your bridge while they're mixing your epi drip. Okay, because epi is going to be good if this is cardiogenic shock. Epi is going to be good for cold shock if it's septic shock, and you're going to be volume resuscitating and supporting the respirations and everything else in the background. Good. Clear as mud?
Any questions, guys?
Okay.
Good.
All right, patient 3. We've got a 4-day-old full-term infant presenting to the ER with lethargy and respiratory distress. Poor PO since discharge on day of life 2. The child comes in shocky appearing with pale, cool extremities and weak femoral pulses. Baby is afebrile, tachycardic, bordering on tachypnic, and again, unable to obtain a blood pressure, and the stats are 94. What could this baby have?
Lena said hypovolemic shock.
Okay, hypovolemic, good. Shock often has multiple things overlapping.
What else in a baby?
Newborn, neonate.
Yeah, Mark said cardiogenic.
Yes, right, so cardiogenic shock. All right, so what are we gonna do for this baby? And this is what I said, the pink shocky baby. So if you're worried about cardiogenic shock in a neonate, you're gonna be worrying about congenital heart disease, right? A ductal dependent lesion. And if you have that, you're gonna have a pink shocky baby or a blue well-perfused baby, or just a gray near dead baby. So if this baby is satting 94% but doesn't have good perfusion, you've got a pink shocky baby. You've got a baby who's got probably okay blood flow to the lungs, but not okay blood flow to the body. All right. So what are we going to do for this baby? I know you're all frantically typing ABC.
Dobutamine.
Okay, dobutamine's a really good choice. Okay, but we've already got a blood pressure that we can't obtain. So remember, dobutamine may cause peripheral vasodilation and worsen your blood pressure. So if we're really highly suspicious of pure cardiogenic shock here, what's your go-to?
Epi?
Yes. Yeah. So we're going to use this. Your epi would be your drug of choice. You could certainly use your dopa or dobutamine to get things started, but likely epi is going to be your drug of choice. Plus or minus some milrinone. You might want to add in a little bit of inodilator to help the peripheral perfusion. And if you're very, very concerned that this is a ductal dependent cardiac lesion, what else do you need right away? What other drip? That no one will ever fault you for starting.
Prostaglandin.
Prostaglandin, yeah. If you're worried about cyanotic congenital heart disease or ductal dependent lesion, you're going to start your epi to get the circulation supported, and you're going to order the prostaglandin right away as well. This is a baby that would have like a critical coarct. This is a baby who could have hypoplastic left or Schoen's complex. That's sort of what they're going to look like. They're going to look like that pink kind of shocky kid at first. Okay. 6-year-old with malaise and a low-grade fever with moderately increased work of breathing, poor PO for a couple days. Shortly after arrival, she becomes hypotensive with bigeminy on the monitors, and her pulses become thready. Temperature is 38, heart rate is 140, resps are 30, BP 60 on 30, and she's satting 92% to start with. What do you think she has?
What do you think, guys? She's pretty tachycardic, right?
Mm-hmm.
Couple days of mild symptoms. Now she's tachying hypotensive. Sepsis could be.
Okay, could be septic shock. What else could it be? I gave you a clue. She's got bigeminy.
Yeah, cardiogenic, so something affecting the heart.
Okay, so what affecting the heart? Low-grade fever, feeling kind of cruddy for a couple days, a little bit of a dysrhythmia, and cardiogenic shock.
Tamponade, but from what? So maybe she picked up some kind of virus that's affecting her heart.
Mm-hmm.
What's that called? Myocarditis. There you go.
There you go. Yeah. So when you look just at vital signs, a lot of times things overlap, and most of the kids are going to have some degree of hypovolemia superimposed on whatever their other kind of shock is, right? But the bigeminy and that little bit of viral prodrome should make you think myocarditis. Okay, so what are you going to do for myocarditis to support her circulation? Does she get a ton of IV fluids right out of the gate? Please say no.
Big no.
Okay.
Big nose.
Good. So you're going to do cautious volume resuscitation, and she's maybe going to need a little bit more to help her circulation and raise that blood pressure up. So what would you use in that? She needs inotropy. She may need a little bit of vasodilation in the periphery. She may need a little bit more chronotropy. What could help you with all of those?
So from Lena and Ryan, epi and milrinone.
Okay. Yeah. So you could use epi and milrinone in combination. That would be a really, really nice starting point, and probably less likely to get you into big trouble. Okay. So she comes to the PICU and is in cardiogenic shock. She's intubated urgently, and you get frank pulmonary edema out of the endotracheal tube. Her perfusion remains poor. She's cool and mottled with thready pulses. The ER started dobutamine because they had that pre-mixed, but she starts getting worsening ventricular ectopy, and she fibrillates. Now what are you going to do?
Lena said defibrillate.
I'm sorry, you cut out. Lena said?
Defibrillate.
Yes, electricity. Okay, so now we're going right to PALS. Okay, you're going to not pass go. You're not collecting $200. You are starting compressions and you're getting your defibrillator ready. And what drug is going to go along with defibrillating her? Electricity plus?
Epi.
Epi, yeah, E's go together. Electricity plus epi. Very good. And then what else do we need to do? This is going to involve multiple phone calls.
She said, call the attending.
I'm already there. Who am I telling to call?
ABC, that's true, Mark, but this kid's heart is in, like, a Pressor isn't going to fix this, right? So what, yeah, Lurie. What can they do at Lurie that we can't do?
What can they do at Lurie that we can't do here?
ECMO, yeah, good job.
Right. So this is a very, very high risk situation where simple pharmacologic intervention is likely not to be enough or may not be enough. So yeah, you're going to shock, you're going to give your epi boluses per your PALS algorithm, and you're likely going to be starting an epi infusion plus your milrinone maybe, right? But you have to anticipate that that may not be enough, and so she has to go somewhere where they have appropriate backup for mechanical support of the circulation. So we've always got to have that in the back of our mind too, that what if our drugs aren't enough? Okay. So now we've got a 16-year-old previously healthy male who's transferred to the trauma bay after falling from the roof. Immediately before his fall, he was heard to yell, "Hey guys, watch this." And then he hit the ground. C-collar and backboard in place, and he's intubated at the scene. He's afebrile, his heart rate is 55, his resps are 14 on the ventilator, and his blood pressure is 62 on 35. He's satting 100%. What does he have?
Neurogenic shock.
Yes, neurogenic shock. So like the ultimate in vasodilatory shock, complicated by no heart rate, right? He's got no heart rate compensation. So his bucket got infinitely large, and he's got no heart rate to help maintain his cardiac output, right? Because when you get overdrive of your parasympathetics or unopposed parasympathetic tone, all right? So no heart rate and a massive vasodilation. What does he need?
Fluids.
Lots of fluids. Lots of fluids. And what else? We got to give him back alpha, right?
Phenylephrine.
Yeah, so he needs phenylephrine, and he may actually need something that'll give him a little chronotropy as well. So we sometimes need some epi in the background also. But yeah, phenylephrine is going to be your first go-to drug in this setting. Good job. Okay, so remember that inotropic support is going to be crucial for the short-term hemodynamic support, but it often comes at a cost. So there's side effects to all of these. You're going to want to use your effects and hopefully some of those side effects to your benefit and the patient's benefit. Remember that milrinone is going to have lusitropy and inotropy, so that's a bonus. And that most of these agents do have that final intracellular pathway of intracellular calcium. So we need to maintain normal calcium levels. And that combination of milrinone plus a catechol may actually be the ideal approach to hemodynamic support of the myocardium. And now you should feel like this. Was that helpful, you guys? Put some of this in context.
Lena says, thanks.
All right, great. Thanks, guys.
That was really good. I'm going to try to figure out how to post this recording somewhere so you guys can see it, okay?
And I'll put the correct version of the slides on Sakai also.
Yep. And next week, Dr. Spence is doing vents.
Yes. Yes. Yeah. So if you read anything in preparation for that, it's that ventilator book chapters that are listed on Sakai. That's probably the best thing to start with. It's really easy reading. It's fast. It's fairly entertaining. I think John has read through a lot of it.
It's really good. Easy read.
Yeah. So that would be the best thing to prep for that one would be reading through that ventilator book chapters that are listed.
All right, guys.
Great. Thank you.
Thanks.